Now let's switch to a regimen that currently have not received FDA approval, which is the lenvatinib plus pembrolizumab. And so it's an interesting situation because LEAP-002 did not meet the primary endpoint, but LEAP-012 met the primary endpoint in the intermediate stage HCC. So what is your take on the regimen, and would you ever think about using this, and what your interpretation about the data?
Well, I mean, I think for LEAP-002, I mean, obviously the concept here is pairing anti-PD-1 therapy, Pembro, with TKI. In this study, the comparator was lenvatinib, which, as we know, had a really profound impact on overall survival in the front line at about 19 months. This study was designed in such a way that there were co-primary endpoints, and the alpha was probably split a bit, so it didn't reach its statistical significance. So the study was technically negative, although there was a separation of the curves. I think with TKIs in the late stage, we've seen very mixed results in terms of a number of studies. There was a cabozantinib assessed in a similar fashion, ultimately a negative trial, and there are others that have had some signal, but have essentially been enriched in a non-Western population. So I think the regimen does have anti-tumor activity, but at least in the metastatic setting, perhaps due to the design of the study, perhaps due to treatment beyond progression, second-line treatment, it just didn't make the cut. Interestingly, here at ASCO 2025, we saw a nice update on the 4-year survival, which illustrated a tail of the curve similarly to what might have been seen with a Himalaya regimen, although hard to compare, but certainly active, but not yet in the scope, I think, of practice, given the failure of the study to meet its endpoint. I don't know if anyone has other thoughts about that.
No, I mean, I think you summarized things very well. I mean, there's no doubt in my mind that it's an active regimen, right? Even though it's not FDA approved, clearly it has a high response rate, it's tolerable, and has impressive overall survival. It's sort of interesting. Lenvatinib was approved based on a non-inferiority study to sorafenib, but it almost beat sorafenib. And then Pembro almost beat Lenva, but didn't quite meet its superiority endpoint. So not only did they split the power in terms of having dual primary endpoints, but they also split the power by developing their regimen in a 2-stage process, which is,
But at the end of the day, right, when you have so many options, why would you think it's better or worse than atezo-bev? Right. Why would I want to use a regimen that, where we are thinking that most likely it was this or that? We have approved regimens which are showing statistical significant benefit and already hard to choose from. So it probably is not going to make that cut.
I totally agree. I mean, I think the data in intermediate stage is certainly interesting. I mean, there's a clear progression-free survival benefit. And in that setting, there is at least a sort of mechanism of action potential advantage of being able to start and stop the anti-VEGF therapy. So, the ability to integrate that with local therapies is interesting. Obviously there's a advantage with regard to response rate and PFS over TACE alone in the intermediate stage, but it's a small study, and I don't know that we're going to see an overall survival benefit, especially because patients all cross over to systemic therapy.
Very nice point. So we've talked about the best patients enrolled in the trial, the all-child POA patients. And so if you look at the patients enrolled in the study comparing to what you see in clinic, so what's the comparison? How do you see a lot of those patients? And how about the patients who are not perfect candidate for trial? How you're treating or making choices, and what's important in terms of selecting treatment?
Well, absolutely. So I think, as I said, real world and clinics are different than what we see on trials. And, the one big thing that catches a lot of people a lot of times is the portal vein thrombus, or the, IVC thrombosis that these patients have, and these studies didn't include. I think we are seeing more and more Child-Pugh A in clinic because of the options that we have available. It's not that they're just getting taste and then come to us when they cannot be taste anymore. So we actually are seeing more and more Child-Pugh A. I really think that is a big shift from when I was in fellowship or started seeing patients in the beginning. And but for patients who do not have that status or cannot treat them with all the 3 regimens that we just talked about, I have given patients, there is data for single agent PD-1 inhibition in that case. There's some data to do lower dose TKI in that case, but I think single agent therapy is probably what most people use in that situation to start with. But fortunately, it's not as common as it used. Previously, I think 70% of my practice was those patients, but now it has probably switched to the other way.
So you do single agent IO versus TKI?
Yes.
Yeah. How about in your practice?
Well, I agree exactly what you said. I mean, we are validating these treatments in a highly select patient population with regard to liver function as assessed generally by Child-Pugh. And as we get out of that population, knowing the full operating characteristics and toxicity is a bit of a challenge. For portal vein involvement, IMbrave 150 did include main portal vein involvement. We know from subset analysis that those patients tend just to do worse overall, and probably that's an area that we need to explore. Is there other local regional therapy, potentially investigationally, in that space? For the B, Child-Pugh B, I agree what's been stated. I mean, we do have regimen TKI-based single-agent immunotherapy. I would say that there have now been studies presented looking at atezo-bev in the B7. There is a durva-tremi analysis, I believe, ongoing. So I think we'll probably have more confidence with that. For the C, this is a real difficult challenge where probably the degree of liver dysfunction may actually drive the survival. Sometimes, though, I still think about it in terms of the status of liver disease, the status of cirrhosis, I should say, or not prior to the disease itself. Sometimes there's decompensation from rapidly aggressive growing disease where perhaps an immune-based therapy would be reasonable. I don't know if anyone else does anything differently.
I think actually your last point is a really good one. I mean, the Child-Pugh system was never really designed to assess people with cancer. And we all have these patients in clinic who are Child-Pugh B because they have a lot of tumor. They're not eating. They feel crappy. Their albumin's low because they're not eating. They've got tumor invading their liver, so their biliry's up a little bit. Those are people that I'm pretty aggressive with in my clinic. And some of those patients respond and their liver function gets better. I think that's a very different picture than the patient who has severe underlying cirrhosis. They're encephalopathic. They have ascites. Those patients I think we have to be more careful with. And so I think this is one of the challenges is Child-Pugh B is a very heterogeneous group of patients.
Right, very, very different. I mean, we've all had patients with a B7 that do extremely well, whereas those with a B7 that are later really deteriorating. And so I think it emphasizes the point for all of us that we monitor these patients closely.
Maybe, honing the point that you mentioned, like competing risk, right? Do you think the risk is from the cancer more or the competing cirrhosis? And that's how you decide how aggressive you would want to be.
I totally agree.